Welcome to our presentation where we're going to speak about shock and the administration of vasopressors. Let's take a trip down the perfusion cascade. Your body contains blood, in particular red blood cells, and the red blood cells have the hemoglobin which carry the oxygen to where they need to be. This perfuses the end organs such as the brain, the heart, and other organs such as the kidneys and tissues. All EMS providers should be aware of the components of perfusion within the human body. Blood, the heart, hemoglobin, oxygen, blood vessels, and red blood cells. A patient may lose blood internally or externally through traumatic events. They may have a reduction of red blood cells in conditions such as anemia, or a reduction of red blood cells may be caused by an EMS provider who has administered large quantities of solutions such as lactated ringers or sodium chloride. The heart may malfunction, or tachycardic or bradycardic dysrhythmias, STEMIs or non-STEMIs. Hemoglobin may be occupied with carbon monoxide or be in low quantity due to the reduction of red blood cells. There may be a reduction of oxygen due to something as basic as an airway obstruction from a patient vomiting or blood in the airway that needs to be mitigated with BLS skills such as aggressive suctioning, reduction in the diameter or enlargement in the diameter of the blood vessels. All play a part in adequate or inadequate perfusion of the brain, the heart, kidneys, and other tissues. Something as simple as keeping a patient warm during a trauma may mitigate the results of hypothermia on the clotting cascade. So this is not just ALS. You can think of the blood pressure in the human body as being controlled by three things: the pump, the fluid, and the container. The heart, the blood or the other fluid, and the vessels. Another value that we have to determine the adequacy of pressure of blood in the human body is the mean arterial pressure. This is the pressure necessary for adequate tissue perfusion of the organs of the body. A map of greater than or equal to 65 millimeters of mercury is needed to provide enough blood to the coronary arteries, kidneys, and the brain. We can determine this value by taking 2 times the diastolic, adding that to the systolic blood pressure, and dividing that value by 3. Or, a more subtle way, is on most cardiac monitors, you will have your blood pressure, and below that number in brackets or parentheses will be the MET. It is important for EMS providers to understand the value of the mean arterial pressure, as opposed to simply looking at the blood pressure and saying, well, as long as it's 90 or above, the patient is adequately perfusing. The mean arterial pressure can be calculated by taking 2 times the diastolic blood pressure and adding that to the systolic blood pressure and dividing that by 3. Consider these 3 blood pressures: 90 over 60, 84 over 40, and 100 over 36. Which blood pressure has an adequate MET? Well, let's break out the big calculator. 90 over 60, 2 times 60 is 120, plus 90 divided by 3 gives you a map of 70. 84 over 40, 40 times 2 is 80, plus 84 divided by 3 gives you a map of 55. And 100 over 36 is 72 plus 100. It's 172 divided by 3, giving you a map of 57. So although one blood pressure, 90 over 60, is lower than the 100 over 36 as you look at the systolic, the 90 over 60 actually is the only one with an adequate MET. Another resource which is a valuable predictor of outcome is the shock index. The values are obtained by dividing the heart rate by the systolic blood pressure. Those numbers are divided in a scale corresponding to either no compromise up to severe compromise. Remember, divide the heart rate by the systolic blood pressure. This particular patient would have 0.8. They would fall in the mild category despite seemingly normal vital signs. In most cases, you'll be required to administer a specific amount of IV fluid prior to the administration of vasopressors. Drip sets come common sizes 10, 15, and 60. This is the amount of fluid coming from the chamber at gravity. The number represents the amount of drops that will equal 1 milliliter of fluid. When delivering fluid at gravity, you should be concerned with the diameter of all tubing going from the bag to the patient. A microdrip set has a narrow diameter, whereas a macrodrip set has a larger diameter. If you learn best through memory aids, think of my friend Little Mike eating a Big Mac. Years ago at EMS, major trauma and bleeding was met with the treatment modality of 2 large bore IVs wide open with fluid, and that was found later on to be actually detrimental to the patient outcomes in most cases after the application of evidence-based research. They found that disturbed clotting increased the amount of bleeding due to the increased pressure unnecessarily and could hemodilute the patients, whereas you're delivering large volumes of fluid, normal saline or lactated ringers, but neither of which have oxygen carrying capability. There are times where you still need to deliver large volumes of fluid to a patient in a short period of time, and it's important to understand that the IV catheters that we use are numbered. The lower the number, the larger the diameter. And this comes down to the amount of fluid that can be delivered over a certain period of time. So a 14 gauge can deliver 240 milliliters per minute, and you can get in about a liter in about 4 minutes, whereas a 20 gauge needle will deliver approximately 60 milliliters per minute, and that gives you about 1 liter over about 17 to 20 minutes. So it depends how fast you want to deliver this fluid and the presentation of the patient and how long the patient can wait. As you'll see in the treatment modalities listed in the next slides, in Rhode Island EMS, you need to deliver approximately 2 liters of fluid in most cases before you switch over to vasopressors. So 2 liters is a lot of fluid to deliver if you're going to be sticking somebody with a 22 gauge needle. Ironically enough, when somebody really needs the fluid, they usually don't have the veins that will accept large bore catheters. So be a good clinician and do the right thing for your patient. ALS providers should have pressure infusers available at their disposal. However, if those are unable available to them, they can use a blood pressure cuff. Just be careful when you wrap that blood pressure cuff around that bag that it doesn't come loose and fall upon your patient. Some students require memory aids to be successful. So here you go. The Presses paramedics in Rhode Island are allowed to administer all end in INE, including dopamine, which actually ends in mine. This is a list of medication and their effect on target receptors. Phenylephrine primarily affects the alpha receptors. Norepinephrine primarily affects the alpha receptors, but also affects the beta 1 and some beta 2. Dopamine receptors that are affected are dopamine, beta 1, beta 2, and alpha. However, the effect on each of the receptors is dose dependent. Epinephrine primarily affects the alpha and beta 1 receptors, but also affects the beta 2 receptors. Phenylephrine targets the alpha receptors, and the alpha receptors act upon vasoconstriction. Vasoconstriction acts to increase systemic vascular resistance, thereby increasing the blood pressure. Norepinephrine acts upon the beta 1 and beta 2 receptors. This increases the heart rate and forced contractions. It also acts upon the alpha receptors. This acts to vasoconstrict, and the vasoconstriction increases peripheral vascular resistance, thereby increasing blood pressure. Epinephrine acts on beta 1 and beta 2 receptors with more beta 1, increasing heart rate, increasing the forced contractions, and has some alpha properties, which acts on vasoconstriction, which increases systemic vascular resistance, thereby increasing blood pressure. Dopamine is divided into 3 different dose segments. Less than 5 micrograms per kilogram per minute acts on dopamine receptors, increases splanchnic blood flow and renal vasodilation. EMS doesn't often use it at that rate in Rhode Island. Dopamine at 5 to 10 micrograms per kilogram per minute acts upon beta 1 and beta 2 receptors, increasing heart rate, increasing forced contractions. Dopamine administered at greater than 15 micrograms per kilogram per minute acts on alpha-1 receptors and achieves increased blood pressure through vasoconstriction, thereby increasing peripheral vascular resistance. Hemorrhagic shock is simply inadequate tissue perfusion secondary to increased bleeding. As humans bleed, they lose red blood cells, which have hemoglobin, which carry oxygen destined for our heart, lungs, kidneys, and other tissues. Bleeding can be external or internal. And external bleeding is very easy to discover and is usually easier to control with direct pressure all the way up to and including a tourniquet. However, internal bleeding may not be as easy to discover. A person may not even realize they're bleeding internally until later after their fall or after their trauma. ALS providers can make bleeding exponentially worse if they're not mindful of the blood pressure and the math prior to administering fluids. Administration of large volumes of fluids can lead to hemodilution, disruption of the clotting cascade, and increased pressure could actually increase the amount of bleeding internally through the hole in the vascular system. This is an excerpt from Rhode Island Statewide Emergency Medical Services Protocol 2.21 Adult Hemorrhagic Shock. In treating hemorrhagic shock, you may deliver lactated ringers 500 milliliters and repeat that to a maximum of 2 liters. Bring the systolic blood pressure greater than or equal to 90 millimeters of mercury and a MAP greater than or equal to 65. Return of palpable radial pulse or return to normal mental status. When treating hemorrhagic shock from penetrating torso trauma with no evidence of TBI, administer lactated ringers 250 milliliters, which may be repeated to a maximum of 2 liters. Bring the systolic blood pressure greater than or equal to 80 millimeters of mercury with a MAP of greater than or equal to 65. Return of palpable radial pulse, and a return to normal mental status. When treating hemorrhagic shock with penetrating torso trauma and evidence of TBI, administer lactated ringers 250 milliliter to 500 milliliter boluses, which may be repeated to a maximum of 2 liters. Bring the systolic blood pressure greater than or equal to 90 millimeters of mercury with a MAP greater than or equal to 65. Return a palpable radial, and a return to normal mental status. For hemorrhagic shock, which is persistent hypotension following administration of 2 liters of IV fluid, you may administer either push-pressor dose epinephrine or phenylephrine, or infused norepinephrine 2 to 20 micrograms per minute, or epinephrine 0.1 to 0.5 micrograms per kilogram per minute. The human body starts off with an infective process. This could be pneumonia, a UTI, anything that's infective in the body can cause sepsis. As the white blood cells are traveling through the bloodstream, they're looking for the infection, and the vessels become leaky, allowing those white blood cells to leave the vasculature and to look for that infection. As those become leaky, the vasculature increases in diameter. So you have a gross vasodilation, which is going to lower the blood pressure, and a leaching of fluid from the vasculature. This is in addition to any fluid losses that may be present due to vomiting or diarrhea, or even marked and prolonged tachypnea. So septic shock is a container problem. As the container enlarges, the blood pressure drops, and can be a fluid problem as well, with loss of fluid from tachypnea or other insatiable losses such as diarrhea, frequent urination, or even perspiration. So your patient needs pressors and they need fluid first. Septic shock with hypotension usually requires aggressive IV fluid management and replacement. We utilize lactated ringers as opposed to normal saline, and we utilize 500 milliliter boluses to a maximum of 2 liters to achieve a desired outcome of blood pressure greater than or equal to 100 millimeters of mercury or a MAP of greater than or equal to 65. If after 2 liters of fluid there is still persistent hypotension, you can either go to a push pressor dose of epinephrine or phenylephrine, or norepinephrine is preferred as an infusion, or you can use dopamine, epinephrine, or phenylephrine as an infusion to achieve that desired outcome. To simplify cardiogenic shock, there's a problem with the pump. There's a problem somewhere with the heart. That could be a non-STEMI or a STEMI, valve problems. It could be cardiomyopathy, but it's a pump problem. Anytime you're about to administer large volumes of fluid to a patient, you should always check the lung sounds and make sure they're clear, but particularly in cardiogenic shock. Remember acute decompensated heart failure. That's a lung problem that's caused by a heart problem of heart that's in some degree of cardiogenic shock. So make sure you're checking those lung sounds. You can start with a bolus of 200 milliliters of lactated ringers and move on with norepinephrine or dopamine. Your desired outcome will be a blood pressure greater than or equal to 100 or a MAP of greater than or equal to 65. Neurogenic shock is usually caused by a brain or spinal cord injury. It results in decreased vascular tone and decreased sympathetic tone. The vascular system without sympathetic tone makes it unable to propel the blood properly, which significantly affects blood pressure. Consider highlight or racquetball, where the player launches the ball at a high rate of speed towards a wall that's firm. If that wall was soft, that ball wouldn't bounce off that wall and return to the player with great speed. The difference between neurogenic shock and other types of shock, as far as the patient's symptoms, is a lot of patients will have a bradycardic rhythm. And this is because of the influence of the parasympathetic tone as the sympathetic tone is reduced. Your desired outcome for treatment of neurogenic shock includes a blood pressure greater than or equal to 100 systolic or a MAP greater than or equal to 65. You're going to check those lung sounds, administer lactated ringers, 500 milliliter boluses up to 2 liters total, then move on to pressors, including phenylephrine, norepinephrine, and dopamine. Any EMS provider that sees one of these in the truck, you may not know what it is, but it's a dial flow, so just throw it away because they don't use them anymore. IV medication may be administered via IV infusion pump or via push pressor dose. There are certain medications which require an IV infusion pump to administer. EMS providers should be familiar with the IV infusion pump that is employed by their service to perform this. For the purpose of this presentation, we're talking about dopamine, epinephrine, norepinephrine, and phenylephrine. These must be administered via IV infusion pump. However, epinephrine and phenylephrine may also be administered via push dose. These are some examples of medications which may be administered by ALS providers in Rhode Island without the use of an IV infusion pump. Push dose phenylephrine has an onset of action time of 1 minute, duration of action time 10 to 20 minutes, adult dose 50 to 100 micrograms every 2 to 5 minutes, and a pediatric dose 5 micrograms per kilogram, max single dose 100 micrograms every 5 to 10 minutes. Phenylephrine push dose preparation is rather easy. You take 1 vial of phenylephrine, 10 milligrams per ml. Utilize a 3 milliliter syringe with a needle and withdraw 1 milliliter, 10 milligrams of phenylephrine. Take that preparation in the syringe and needle and add it to a bag of 100 milliliters normal saline. Label that bag for safety. Take that same bag, utilize a 10 or a 12 milliliter syringe and needle, and withdraw 10 milliliters from the bag. You now have 100 micrograms per milliliter. Make sure that you label that syringe so someone doesn't confuse it with a normal saline flush. Push dose epinephrine is going to have an onset of action of 1 minute with a duration of action of 5 to 10 minutes every dose. The adult dose is 10 to 20 micrograms every 3 to 5 minutes, and the pediatric dose is 1 microgram per kilogram every 3 to 5 minutes. In order to create an epinephrine push dose preparation, you're going to take epinephrine, formerly known as 1/10,000, 1 milligram in 10 mLs. You're going to take the glass vial out, pop the plastic cap. You're going to use a 3 ml syringe with a needle, inject it through the rubber stopper, and withdraw 1 milliliter of that drug. Set it aside safely. The next step, you can do 2 things. You can take a 10 milliliter normal saline flush and empty out 1 milliliter, leaving you with 9 milliliters left in the syringe. Or you can take a 10 ml syringe and just draw up 9 mLs of saline. Either way, you're left with a syringe with 9 mLs of saline. You're going to take your 3 ml syringe with 1 ml of the epinephrine and slowly inject it into the syringe containing 9 mLs of saline. And now you have your preparation. Make sure you add a caution sticker to that syringe. If you do not have epinephrine 1 milligram per 10 ml premix, You can make it using epinephrine 1 milligram per 1 ml. You're going to take a 3 cc syringe with a needle, pop the cap, take out the 1 milliliter, 1 milligram of epinephrine. You're going to take your syringe, get rid of 1 milliliter. Then you have 9 milliliters of saline in your syringe. And you're going to add that 1 milliliter of 1-to-1 epinephrine, and that will be the proper 1/10,000 or 1 milligram per 10 ml mixture, which is the same as the Burstajet. And you can continue on with your push dose preparation from there. Thank you for taking the time to view this presentation. Rhode Island EMS providers should always refer to the Rhode Island statewide emergency medical services protocols and/or medical control when considering treatment options.